Dr. Alex Singer is a practicing family physician, clinician, teacher, and an associate professor in the Department of Family Medicine at the University of Manitoba, where he serves as the Director of Research and Quality Improvement. He is the Network Director of the Manitoba Primary Care Research Network, where he leads and collaborates on several regional and national practice-based research studies. Dr. Singer's research focuses on using information technology in primary care settings, specifically in the areas of disease surveillance, practice-based research, and learning networks, and pragmatic clinical trials based in primary care settings. He has published and presented on several topics, including quality improvement in primary care, chronic disease management, and resource stewardship in primary care. So, looking forward to hearing from Dr. Singer today. I'll pass the floor to you to present on addressing disease risk factors in primary care settings.
Okay.
Thank you for joining us. Always love
Thank
your
you.
presentations.
Okay. Can you see my slides? Did
That
it?
is perfect. Thank you.
You see the right slide deck, yes?
Yes, we can see the
Okay.
quote at the top. Yeah.
And make sure it advances. Hold on. I have too many screens open. Uh, Can I make it advance? Okay, I think I got it to advance.
Perfect.
All right. So I'm
Thank
joining
you.
you from the University of Manitoba, which is, of course, located in Treaty 1 territory. So, excuse me. Just wanted to acknowledge that and that I have the privilege of getting to live and work and play in this wonderful place. Since we're going to be talking, and I guess you guys have been talking, I was tuned into some of the HIE discussions already. And since we're talking about measurement and data, I thought it just interesting as opposed to doing this sort of standard, read the land acknowledgement. I thought it was interesting to just think a little bit about mathematics in a more indigenous fashion. This is an expert, this is a professor from, I think, University of Regina, Edward Doolittle. A few great quotes there about a sort of an indigenous view of measurement in mathematics. And I think the learning here, and one of the things that I think is very relevant and we should be cognizant of, is that, sometimes we think of math and, statistics as kind of like Western science, that kind of thing. But this idea of observing the world around us and measuring and addressing what we see goes back to the first peoples of this country and to other sort of through lines through history. So, I think in particular, situated in Canada, we should sort of think about this a little bit, sort of the land and the environment around us, in addition to, the people and the healthcare, obviously, that we provide to people. So I'm a family doc, so I, I try to think holistically. And then, of course, my research side, we do lots of measurement and evaluation and things like that. So, just very briefly, some conflicts, nothing specific to what I'm going to tell you about today. And all these projects are actually a bit older at this stage. I don't know if there's a statute of limitations on some of these. This is more or less what I'm going to try to cover in terms of learning objectives, really giving you a flavor of sort of the importance, clinically speaking. You guys are all in a master's program and it's not necessarily entirely clinical, but I want to try to ground some of this discussion of standards and content and informatics in some actual clinical pieces. I'll talk a little bit about practice-based research and learning networks, which is where a lot of my research is situated, just as a way of understanding how some of this work actually happens within sort of a medical, at least a primary care context. And then we'll talk a little bit some future state stuff and have some, hopefully thought-provoking slides about where things are going in relationship to content and informatics, from an AI in the world of AI, which has changed. So this presentation, I used to think it was very advanced, and then when I looked at the slides, it's like, oh, they're getting a little dated because of all the new advances. So we'll talk a little bit about risk factors very briefly. Just a little mention, I want a little plug for COVID, which for some people unveiled this concept of social determinants, which, in healthcare, lots of us knew, and certainly in family medicine, primary care, very much at the front of our minds, even well before the pandemic. But the pandemic exacerbated some of those adverse social determinants, and it made it a little bit clearer for folks. In many ways, it became more apparent, like it's a virus. Why should poor people be dying at a higher rate than wealthier folks? And some of those disparities became really unmasked in some ways, even though they were there prior. And of course, my bias is, of course, that I think that practice-based research networks are really a way to help us understand some of these risk factors at the individual clinician level. It's very difficult. I mean, you see individuals, but to be able to combine data and pool it, we need these sort of networks of practices. So I mentioned the piece about COVID. Uh, but as I said, that this map of Winnipeg, I don't know how well you guys know Winnipeg, but it's pretty obvious. You can see geographically there are certain neighborhoods where your life expectancy is lower. And these map very close to socioeconomic sort of determinants. And so you can see in this map of Winnipeg, and many other cities have done similar type maps. These exist in other places. There's probably one of Vancouver and Victoria. But you can see the downtown core, male life expectancy less than 70 years. You move out to the suburbs, particularly the wealthier suburbs in the south and one of the more affluent neighborhoods in the north of the city. Suddenly, the life expectancy is almost 10 years different. And then, you have this kind of wrap in the inner core, more sort of working class, working poor, and the same pattern for women. In fact, even more pronounced, although women do a little bit better even in the poor neighborhoods. And so this is really dramatic, and it tells us something about there's nothing genetically really different about Winnipeggers who live over here than over here. And, they might even shop in the same grocery stores and things like that, but often not because there's a whole suite of reasons why by neighborhood things can be very much, much different. But so the concept, and I think I probably don't have to talk too much about this, but this idea of you can't measure it, you can't manage it. It's sort of a bit of a truism. I like Don Berwick's line, which is sum is not a number and soon is not a time. For many years in my office, I had this posted on there that said hope is not a plan because some regional health authority person said that in a meeting. And then I was quoted apparently by our prime minister, who recently said hope is not a plan and nostalgia is not a strategy. So just a way of thinking about this, that like this business of measurement is essential if we're going to actually be able to address these issues. It's not the only thing we need, but it is essential. If we don't measure things, we don't know what's happening, and we don't know if all the investments we're making in healthcare or other things are actually making a difference. The other concept I just wanted to touch on briefly, and again, I suspect some of you probably know this a little bit already, this idea of GIGO, garbage in, garbage out. And this is very true and apparent in health data, because all the things you're learning about standards and health content and all this stuff really haven't been rolled out yet. Like we have a pan-Canadian framework and we have concepts and we have, an approach and an implementation plan. But right now, today in healthcare, if you go in, the data is messy and dirty and not coded to a standard. And so you have to be careful when we start using this data. And I think some of the slides I'm going to show you in a little bit show some of the work that I've participated in that sort of helped to try to consolidate some of this. But it's really important as we actually start to use data to really be considerate to this. And I think AI has put this into steroids because a lot of these models come up with wonky things and they hallucinate. And that's not necessarily a feature. That's not a glitch. That's a function of how they've been trained and the data they've been trained on. This is a famous example from now many years ago, 7 years ago, where there was a health insurance program in the United States. They were trying to identify who their high-risk patients were. And it seemed that all of their high-risk patients, or there was a predominance of their higher risk patients that were being selected for this outreach service, were actually white. And it sort of, and the neighborhood was not predominantly white. And so it sort of pose the question, is the algorithm racist? Or rather, it's not that the algorithm is racist. The algorithm was biased because the data that trained the algorithm was biased. And so in this case, because the algorithm is agnostic, it was just built on training data. And so the outcome was very harmful to folks who would have benefited from this additional service, but their insurance company never identified that they would be eligible because they were primarily uninsured or had other issues. And so then the algorithm itself was incorrect. And so this issue of not having good training data leading to biases and then not having programs that respond well. This is this is one of my favorite quotes around coding is caring. We do a terrible job of coding and keeping consistent data standards as physicians, but we don't have to be limited by this. The irony of this quote and the sort of establishment of this as something that was important is that it goes back to 1968. So we've known this for a long time, but we've created a system that has done a pretty crappy job of actually maintaining a content standard. And so practice-based research and learning networks have sort of evolved in Canada within this ecosystem. And one of the things that we've taken on in PBRNs as a sort of research necessity and as users of health data and in primary care or health or family medicine research, really our practice data is our research. We can't take apart families and bring them to the lab like you might if you were looking at an organ. When you're thinking about family medicine, our research space is the data, is the populations, is the patients we serve in their communities, which means PBRNs really have to pull this stuff together. And so I'm going to explain a little bit about sort of PBRN's roles in Canada in terms of measuring risk factors and how we can sometimes also use surrogate measures to sort of contribute to this idea of having a learning health system, which could actually be responsive. This is sort of a dream and a hope that the health system would actually be responsive to the data that's being produced so that the delivery would inform the actual services and the research would inform the delivery. And so this sort of closed loop, ongoing continuous improvement kind of loop. So when it comes to alcohol and tobacco and substance use, so we know that these are behavioral risk factors. People smoke, they drink sometimes too much, and they use substances sometimes too much. And this information gets documented in medical records. So a colleague of mine, Michelle Griever, many years ago, I don't have the date on that study, but it's got to be more than 10 or 15 years old. She did this study looking at tobacco use and how it was documented in electronic medical records. And within our PBRN, we then took that and used that to help us clean up the tobacco data. And then a couple of years later, I thought it was such a great idea that I replicated it. But this time we looked at alcohol use. And so I'll explain to you what we did just to get a sense of how that operated. So number one, this is probably hopefully not news to people, but alcohol turns out to be a driver, or alcohol use turns out to be a driver of many health outcomes, negative health outcomes, and that is. You can attribute alcohol use or overuse to about 7.7% of the deaths. That was from 20 years ago, but it hasn't changed much. And it's associated with major medical comorbidities. And so that's why we probably should record it in a medical record, because it's such a huge contributor to other conditions, comorbidities, mental health, physical health, a whole bunch of different things. And so if we're going to target patients who might overuse alcohol, we have to know who they are. This is just a slide that medical students sometimes like that shows you all the take home from this slide is all the places that the alcohol touch can give you problems. But who actually has this documented in their record? So when we did this study, now again, this goes back a few years, but at the end of the day, it hasn't changed much. I can tell you because I still see this data. It hasn't changed much. Only about 40% of the patients in our research repository, so people who'd agreed to share their data and participate in this PBRN, the billions of people across representing millions of patients, 1.6, I think, at our largest. In Manitoba, it's about 250,000 or so patients spread across 50 clinics. So wide geographic range. Only 40% of them had their alcohol documented. Alcohol use documented, I should say. Now, there's some trends that were not surprising, right? More commonly documented in males. Males tend to drink a bit more than females. The older you were, the more likely it was to be documented, so more opportunities potentially. Patients who saw their primary care provider more than 3 times a year, so if you come a lot, your chart gets more complete. And particularly those that had comorbid conditions that might be associated or exacerbated with alcohol use, and the heavy consumers had a much more likely use. But all of these were very modest increases, right? Like 1 to 3 times in the odds ratios. What was more challenging with this study was how crappy the data was, because most of it was free texted in. To this day, we still don't have a standard. I mean, a standard exists, it just hasn't been implemented. So hopefully with the help of our friends at HIE, it'll eventually get implemented. But it's going to not happen overnight in Canada because all the provinces are going to drag their feet, and there's going to be all sorts of issues, and Quebec won't do it. But this is what it looks like now. So this is just a small snippet of some of the crap that was in the EMR that then we had to build an algorithm to clean up. And so when I say we built an algorithm to clean it up, this is the easiest kind of example of how sort of we go from EMR text, which is sort of, long strings of stuff. This is in the case of medications, to a cleaned text, which gives you, to a clean set of text, which gives you sort of just the drug, and then a code, in this case, an ATC code, which is for medications, right? ATC codes is just a coding standard like ICD-9 or LOINC, but specific to medications. And so what the algorithms do in our PBRN is essentially try to clean up the data when it looks like this, because this is a specific branded medication, but we don't want necessarily to compare all the people on this specific branded medication. We want to know all the people on insulin glargine, and then even better, have it as a code. So what we did for the alcohol use documentation was we had this kind of natural language processing pipeline. That's what people are calling it these days. I don't think we called it a pipeline back then, but it does kind of have a flow. We did we developed a reference standard, we trained the model, and then it was very basic natural language, right? Processing like unigrams and bigrams, and we basically just sorted all the text. The stuff has gotten way more complicated now with large language models and stuff. But this was good. This goes back a bunch of years. And it was published in 2021, but we'd actually did the work quite a bit before that. And essentially we cleaned up the alcohol documentation sections, and then we were able to classify non-drinkers, light drinkers, moderate, heavy, and fast drinkers. And so basically we were able to show that it was possible. We were able to do it. It was neat. We got it published. But this is an example of sort of the old style of NLP, or natural language processing. Now, those old NLP models, the sort of basic algorithms that you can sort of read text and classify it and understand, have been combined with large language models. And when you put an NLP and a large language model together and a whole bunch of other programming, that's sort of what AI is, more or less. I mean, a couple of other components and parts, right? So the way that we would do this now in 2026 is totally different than the way we did it back in 2019 or 2018, 2020 when we did the study, and then beyond. I want to mention just a little bit in terms of social determinants beyond sort of the coding and the documentation in the EMRs. We still can use postal codes, and that's a really useful. You saw the math there, and I want to show you a study too that we did that just demonstrates how the precision that postal codes can give you when you're trying to tease out some of the effects of social determinants. And then, of course, maybe one day we'll have interoperable data. So, I'll make a few pitches at the end about interoperable data. So this is the AI version of, in 2025, 2026, of these kind of scalable models. So I have just a bunch of slides, just a bunch of papers, manuscripts that I just was picking around and reading today, so I could update the presentation. So this one's a scalable model for using free text, published all the way back in 2025. And what's amazing, what these guys did was they actually compared different large language models, or different sort of AI large language model programs, and they measured the sort of which ones provided different invalid responses. So you can see different models, different AI large language model programs give you different amounts of invalid responses. So these things aren't like out of the box ready. We have to train them and make them right and fix them. This one was very cool. It's a very busy slide. The point of this is just to show social determinants. They built a social determinant GPT, basically based on sort of a chat GPT kind of approach. You can see this is their pipeline. The accuracy increases as they got the training data through. And then they got it up to, this was really cute over here. What they did was they compared the human coding with the two-shot social determinant chat GPT, and they showed that they're both over 95% accurate. So that's good. The humans took 613, or they estimated a cost, $613 to run this for the humans and $32 for the AI to do it. And the time, of course, that's probably where all this cost comes from, 310 human hours and 23 AI hours. So this is an interesting idea that like some of the things that we're going to be able to do with AI when it comes to cleaning and coding data, it is really just to compress the time and sort of accelerate what you might have been able to do if you could build an algorithm slowly and validate it and test it and fix it. And so these things are all basically hitting the market and starting to be available for research, now. So this was just published in JAMIA this year. And then again, just a couple other examples of social determinants of health extracted from clinical notes using large language models. So this was their pipeline. They sort of, did this kind of process and then did the model training with different approaches and BERT and LLM and things that I don't quite understand, quite frankly. But again, good success rates. And this other one, same thing, large language models. And they showed like north of 95% accuracy for all the different models using sort of a ChatGPT trained approach. So really interesting what's going to be possible. And what's happening in the AI space is things are moving faster than we can even imagine. Every week, some new application comes out, but we are wickedly behind in Canada. Basically, most other countries in the OECD have near interoperable or mostly digitized data, and we are way behind. We're the only country in the OECD unlikely to have available interoperable EHR data in the next 5 years. So that's a profound and serious gap, and it's going to affect our health system if we don't really pick up our socks and get this. And so it's been a long time running, and sadly, some of the leaders in this this has been a problem for so long, people are passing. This is just a little homage to a mentor of mine, Louis Oppenheimer, who was screaming about this, before when I was a med student before. So we really have to catch this up. The question, and this is a bit provocative, but like, will AI actually fix this? Or are we just, basically building technology that will put us all out of work? It remains unknown. Some of my favorite sci-fi versions of AI are on the screen, but really this is an unanswered question. The technology is moving at such a pace that it's being deployed without good measurement. It's being deployed without reasonable valuations, and it's being deployed and we are all participating in experiments of artificial intelligence being used in the real world, sometimes in healthcare settings, as we go. So it's real time being experimented and changed. And we would never deploy, in the past, we would never have deployed a health technology or a health application without rigorous studies. For some, because AI is wave your hands, oh, AI is exciting, we are deploying this at breakneck speed. So, we're both behind, and maybe that will save us, or we're behind and maybe everyone will be doing things that we should have been doing and will be, left in the dust. So this is really an interesting time to be watching this and to be someone who's historically been, myself, a health optimist or a techno optimist, now somewhat fearful of sort of what's coming with AI. Let me go back. So AI aside, some of the basic techniques and available data to understand social determinants are still out there, and AI is not going to replicate them. Census data, which is connected to postal codes, is still one of the mainstays and is extremely useful when you're trying to measure social determinants. I'm going to give you just a quick snapshot of a couple things that I've been involved with, and then I'll try to get to the end so I can get some questions. So just so you know, this is the definitions for social and material deprivation. They are different and they're composites. So social being different aspects of the people who live in your neighborhood, and the material is more focused on income and unemployment, education as well. So not all deprivation, if you think about social and material deprivation, it doesn't always have the same effect. So this is just an example from a study my team did around blood pressures in children or hypertension in children. And the material deprivation in this case had a statistically significant effect. The social did not, and the combined score did not. So just because it's so composite indexes do these kind of funny things. If you fast forward, pediatric hypertension sometimes leads to adult hypertension, which then leads to kidney disease. There are other things that lead to kidney disease, of course, but this is one of my favorite sort of differential slides because it's so blatant when you look at it. Basically, what's happening here is the the most deprived people are the most likely to have chronic kidney disease, which means essentially we are treating poverty with dialysis. And it is a profound difference, right? If you look at chronic kidney disease, the scores go right in order of deprivation. So if you walk through the dialysis ward, 50% or more of the patients are in the lowest socioeconomic class, and 30% or less are in the highest. So chronic kidney disease is a disease of predominantly 50% or more low income folks. And that is profound, and it leads to worse health outcomes. And chronic kidney disease is somewhat of a harbinger of other conditions, right? Like heart disease and things like that. So same effect in heart disease. PTSD, we did a study on this not too long ago, where we looked at and we found the same patterns as CKD. So you're much more likely to suffer from PTSD, which is of course a mental health condition, completely different than kidney disease, different drivers. But again, social determinants play a huge role in who gets diagnosed with PTSD. And you can see here just the differential, right, of patients with and without PTSD. So much higher in the more deprived groups, like 37% to 6.2%. Like that is dramatic, right? And so both physical and mental health conditions, again, this huge differential that we see. And this is using postal codes, which, it's not individual level data. There is some blur, but at the aggregate, these things are true. And you can see, odds ratios of 2 to 4%, or two to four times, depending on how you measure social or material deprivation. You heard Jennifer Lawson talk a little bit about Spark. I'm not going to get too far into it, but Spark has done a great job of sort of laying out a way that we can more granularly collect social determinant information at the sort of clinical side. And they've done a great job of disseminating this information. And I think a lot of it's been incorporated into the standards. And the other thing that Spark has shown, which I think is really essential, is that patients are comfortable with their healthcare providers asking these kind of questions, because that's often the pushback you get from physicians and nurses and clinicians. People won't be comfortable if I talk to them about their housing or their employment or their education status. Turns out most people are comfortable, so long as they know that data is being used by a trusted professional. And so we participate in some of this work, sort of validating some of these tools that Spark ended up disseminating. So where does this all leave us? We have these standards that you guys heard about. There's the strategy, that Pan-Canadian Health Data Strategy, and this idea that if we can follow the strategy and build interoperable data, maybe we'll be able to have a learning health system where the data actually feeds the information that is generated by the delivery of care actually is connected back. And I like this version of a learning health system sort of model that's sort of a tree that grows in the roots of all the components, part because I like gardening, and but also because I think it's a useful sort of way of thinking about a model for a learning health system, which is a living and breathing organism. This is my cheeky slide about its privacy is not the barrier. The barrier is entirely policy and governance, but sometimes people throw out privacy as the reason. It's not. And then just sort of where we should be going, which is this digital system. Lots of reports in Canada. So if you want to spend the rest of your master's learning about all these reports, and not nearly as much implementation. But I will say, as someone who's been doing health research for a long time, interoperability reports have some of the most clever names. Interoperability Saves Lives is among my favorites, but I love connecting the dots, and the time to act is now. They all have some of them have boring names like the shared interoperability roadmap, but we need to actually start doing this work. We need to stop writing reports and to actually start getting onto it. And I think we're getting just about there. So that's all I have to say for you this evening. I hope you appreciate that, risk-taking behaviors and social determinants do have a profound impact on the health of people. We need to measure these things. Hopefully we need practice-based research and learning networks to collaborate, collect these measures, be able to use them in practice. And hopefully as we drive towards interoperable systems, we'll be able to do this better in the future. So thanks for listening. Sorry for going a minute over. I'm still happy to answer a question too if Linda will give up some time in her workshop, but I don't want to cut too far into that. So thank you.